So I would like to welcome all to this concurrent session, Challenges in Remote and First Nations Care Delivery. My name is Mary Deren with the Saskatchewan Health Authority, and I'm a member of the eHealth 2022 Program Planning Committee. This session includes two 15-minute oral presentations. If you have questions or comments for our speakers, please type them directly into the Zoom chat and we will address them as time allows. You're also encouraged to connect with speakers after the session via the virtual event platform. I'd now like to welcome to the virtual stage our first presenter, Gurprit Randhawa, Director, eHealth and Virtual Care Innovation, First Nations Health Authority. I'll pass it to you, Gurprit.
Thank you so much. Hi, everyone. I'm Gurprit, and I'm absolutely delighted and privileged and honored to be coming to you today from the traditional unceded territory of the Lekwungen-speaking peoples of the Esquimalt and Songhees First Nations on Vancouver Island. And it's such a pleasure to be presenting today on the innovations in Indigenous health that First Nations Health Authority here in BC has been advancing. I've been in the director role and with FNHA for the last 7 months, and today I'll be sharing a lot of the incredible work that our team has done over the last few years, as well as some of the work that we're in the middle of and what's ahead as well. And so I'll provide first a little bit of background about FNHA, as well as the background and purpose of our innovation and some of the different approaches we've used to really advance our virtual care and our digital health, and hoping to share with you as well where we're at today and where we're also going. And please feel free to share your questions, ask your questions during the session, as well as to connect with me offline. So about FNHA, it is the first province-wide health authority of its kind in Canada. And that in itself makes it a very innovative, leading frontrunner in advancing Indigenous health. And FNHA is the health and wellness partner as well to over 200 diverse First Nations communities and citizens across BC. And our vision is healthy, self-determining, and vibrant BC First Nations children, communities, and families. And this image here on the right really speaks to the holistic, with a W, approach and perspective on health and wellness. And so first, a little bit of background on what really brought us to where we're at today in our virtual care and digital health at FNHA. So the dual public health emergencies of both COVID-19 and the toxic drug supply crisis, as well as compounded by the systemic racism in the healthcare system, has resulted in calls from First Nations to accelerate the implementation of new virtual care pathways and digital solutions to improve access to healthcare for First Nations citizens and their families. And so to this end, the FNHA has successfully launched and is currently operating 2 new virtual pathways, as well as we're in the middle of deploying a very large pan-provincial First Nations EMR. So in terms of our methodology and approach and how we've designed, how we're delivering, how we're evaluating our virtual care pathways, as well as the EMR, our work is truly grounded in 2 principles: cultural safety and cultural humility. So when cultural safety and cultural humility are enabled, First Nations people are most likely to access care when they need it, as well as to access care that is appropriate to their wellness beliefs, to their goals, and to their needs. And so in this way, our virtual care pathways and EMR project are really theorized as a component as well to a wraparound team-based system of care which may also encompass other physical and wellness health practitioners as needed. Again, going back to our vision and our holistic model of health and wellness. And so, what have we been up to over the last couple of years? In April 2020, FNHA's eHealth team designed 2 virtual care pathways that followed an extensive process of internal and external stakeholder engagement, planning, clinical workflow mapping, development, and implementation. And as a part of that, we also introduced an EMR. We know very well, and the research shows too, that in order to advance virtual care adoption, having an electronic medical record or other electronic health record system is really, really critical. And so we introduced an EMR as well at that time. And I'm really pleased to share that in June 2021, FNHA submitted a proposal to the BC Ministry of Health to expand use of the EMR across 47 First Nations communities in BC. And again, both the virtual care pathways and the EMR are truly intended to support team-based care with a variety of physical and wellness practitioners. And again, that vision of the wraparound team-based care strategy. And so this slide depicts a bit of what our 2 services entail. So we have the First Nations Virtual Doctor of the Day, which is really focused on primary care services. And it's staffed by families, practice GPs, and it's really the referral pathway. There's more details here on the slide, but essentially the intention of this service is it's virtually delivered. It's a low barrier service, and it provides direct access to family physicians and GPs. And the aim of this service is really to provide culturally safe care to First Nations people in BC who have limited access to healthcare services in their communities, as well as who must have to travel long distances for appointments, or whose access to healthcare has been disrupted as well by the pandemic. And the beauty as well of this service is that First Nations peoples and their families, well, that's the other thing too, both of these virtual care pathways are not just available to Indigenous people, but also to their family members who may not necessarily be Indigenous. And so they can access the service by calling a toll-free number, and the appointment itself is hosted on Zoom with a phone connection as well as a backup if connectivity is an issue, which in the First Nations landscape connectivity is often a challenge that we do have to have a good contingency plan for to really support access to care. Now, the other service we have is the First Nations Virtual Substance Use and Psychiatry Service. And this is a direct virtual pathway, again, for First Nations people and their families to directly access addiction specialists and psychiatrists. And so in advancing this program, FNHA continues to take a leadership role in delivering culturally safe and culturally humble care that can be accessible from anywhere. And I just wanted to mention again the team-based care nature of both of these services. And what's really important too is that this is work that we've done truly in partnership with our First Nations communities. And some of the themes that have come out of this First Nations-led development and advancement of virtual care is that this is truly speaking to innovation. It's speaking to the systems level of change and really moving forward and making transformation happen. And so moving on to, let's just provide some more information about our slides. Sorry, not our slides, but a bit more information about our services. But essentially, I wanted to really speak to how incredible the uptake has been on these services. And truly, it has been such a humbling experience, like really coming in and learning and standing on the shoulders of giants to see how such a relatively simple innovation has made such a profound and powerful impact. So we've seen significant adoption of these virtual care services, and we've received extremely positive client feedback on the experience of cultural safety, timely access, and access to coordinated care. And in the spirit of truth and reconciliation, in terms of the trust that we've built with community, really, I don't have words to express how incredible that has been. And also just the cultural safety of clinicians and the learning that has come with that really has been quite amazing. And what we've seen as well is that over time, as clients have accessed and received culturally safe care, as well as quality care, that our adoption just continues to rise. And I wish I could share a bit more about some of that data that we have to really reflect the adoption and the uptake, just given Indigenous health principles related to ownership, control, access, and protection of data. We're unable to share those today, but we're just in the process of working through with community. Again, this is the community's data to be able to share some of those numbers to really further paint the picture of how incredibly impactful this service has been. So the other project that I wanted to share with you is the Pan-Provincial First Nations EMR. And so what we are doing is basically deploying one single instance of an EMR for all BC First Nations. And the intention is to be community driven, role-based, and to provide auditable access as well. And this EMR that we're using, it's called MOAS EMR. It's built in BC for BC. It's also part of the BC Health Data Coalition to support provincial interoperability. And a lot of our focus with the initial implementation, so we're only reaching out to 47 at this point of the 206 First Nations communities, with the hope to hopefully secure more funding and scale and spread beyond the 47 communities. A large part of our community concentration is in the north, and we're proud and pleased to be deploying MOAS, which is the #1 EMR in Canada. And this just speaks a little bit more to what are some of the functionality that you would see in the MOAS EMR, quite similar to what you would see in a typical EMR. And this slide depicts some of the future capabilities in terms of integration, linkage, health information exchange with some of the other systems in the BC ecosystem. And I'm sure you are all quite well versed with the benefits of an EMR, but just to highlight, we're really looking to reduce information sharing barriers, to really support virtual and face-to-face care and continuity of care, as well as improving security through role-based access, promoting collaboration of healthcare, and really advancing our reporting as well. This is our very unique EMR delivery model. So this is truly contextualized within the Indigenous health landscape. There's 6 key steps to this model, starting with outreach, moving on to engagement. And this is really where we focus a lot of time, attention with our communities and really working with communities and being led by communities in First Nations-led care. And then moving into assessment and planning, development and implementation, training and evaluation, and then continuous support. And this model itself is quite iterative. So we'll be working through with each community, working through this model, really take the lessons learned from each iteration and apply them to each of the future iterations of the system implementation. This shows our EMR timeline for the next few years. And so really continuous delivery approach, focusing on engagement, as I mentioned, assessment and planning, development, implementation, and training. And this is a high-level overview of where we're deploying the EMR over the next few years. So really that concentration up in the north, and then some communities as well in the interior region of BC, and then also on Vancouver Island.
Excuse me, Gurprit, we have reached the 1:15 mark.
Okay, thank you so much for
So-
that reminder. I will just summarize then and just share that FNHA is really leading the adoption of innovative digital health solutions to advance cultural safety, access to care, and connectivity. And I'm so grateful to be a part of the journey and really looking forward to working not just with our First Nations partners, but our partners across BC and the country and even internationally to really walk together and learn and improve health for Indigenous peoples. Thank you so much for taking the time to listen. And I look forward to going through the questions as well.
So I'll just refer you to the chat. There's several questions there. So thank you, Gurprit, for sharing the story of FNHA's innovations in Indigenous health. Up next, we welcome Cindy Clarke and Ashley Dinn from Newfoundland and Labrador Center for Health Information.
Great, thank you. I guess I will jump right in and start. My name is Cindy Clarke. I'm the Director of eHealth Programs for Community and Virtual Care with the Newfoundland Labrador Center for Health Information. I will begin by respectfully acknowledging the province of Newfoundland and Labrador, of which the city of St. John's is the capital city, as the ancestral homelands of the Beothuk. Today, these lands are home to a diverse population of Indigenous and other peoples. We would also like to acknowledge with respect the diverse histories and cultures of the Mi'kmaq, Innu, Inuit, and Inuit Inuit of this province. I will begin with a little bit of information about the Newfoundland and Labrador Center for Health Information. We support the regional health authorities as well as the patients and communities they serve in the delivery of health information technology and eHealth services in healthcare system to provide quality care. The center's mandate also includes the development and implementation of a confidential and secure provincial electronic health record, as well as other provincial clinical information programs, including the change management required to support the adoption by end users. Our provincial virtual care program utilizes virtual care applications and technology to assist in the delivery of equitable healthcare services to citizens of Newfoundland and Labrador, regardless of where they live. The program is accountable for the provincial leadership and direction in the development, planning, implementation, and evaluation of initiatives related to virtual care, including virtual visits, telehealth, secure messaging, and remote patient monitoring technologies. As you'll see, Ashley's put up the overview of our presentation. It will be short but sweet. We have a lot of information, so please feel free to ask questions, and we will certainly get back to you with all and any answers that we have. Ashley, thank you. In order to better understand the virtual care setup in our province, we must first have an understanding of how we got here. Newfoundland has a population of approximately 525,000 people who are dispersed over 370 square kilometers. So our province is spread out. It's very wide. But we have learned a lot that technology has a unique way of digitally connecting and bringing these people together. And in fact, virtual care actually started in this province over 40 years ago as telehealth services. Our province has been very fortunate to obtain hundreds of telehealth units that are in locations all around the province. The map you're looking at now shows how the units in our healthcare locations are dispersed. You can see they're all over the island as well as across our big land of Labrador. The red dot you see are our actual healthcare locations that have the telehealth units. And these are only the units that have been dispersed within the healthcare facilities. There are other units that are out dispersed within our healthcare providers' hands. Over the past year, we were challenged with physician shortage that began to impact our emergency departments. So in partnerships with our regional health authorities, we were able to set up virtual ERs. These are illustrated in yellow as yellow stars here on this map. One note you'll see, there are no yellow stars identified in Labrador. and with regards to the virtual ER model. The reason for that is because this model of care has been there for quite some time. Due to the remote nature of that region, that part of the region, it is integrated into their normal operations in their healthcare sites. So the actual model of virtual ER has been there in existence and are more or less new to the island portion. The map you're looking at is an interactive map, and it illustrates how broadly available our sites are. Anyone can go into our website and click on the telehealth interactive map, and it will give you information about the location of the virtual care service, the health facility that's there, and some telephone numbers and contact information. So we will share that link in the chat as we move forward. At this point, I'm going to pass it over to my colleague, Ashley. And Ashley, I'll leave it to you to introduce yourself.
Yeah. So I'm Ashley Dinn. I am the program manager for virtual care at the Center for Health Information. So I'm going to look over our current solutions as deployed today, and then kind of do a little bit of a deeper dive in some of the areas. So we do work off an on-premise Cisco infrastructure, and we are moving to a hybrid model with cloud services. We have a number of different software solutions. So as you can see in the little buckets there, we have WebEx, Cisco Jabber, and Zoom as our software solutions. We have our traditional endpoints, Cisco-based carts and Amwell carts, and then we also have peripheral devices. And our two main devices right now are the GEDMED examination camera and the eHealth Echo stethoscope. So based on this, as the province prepared for rapid change in the delivery of healthcare due to the pandemic, we needed to leverage more virtual care solutions. So this is why more of our software solutions were rolled out during this time. So our province was very fortunate because we already had the baseline with our Cisco infrastructure, and we were able to adapt quickly to the anticipated demand. So we increased our demand for virtual services and adopted more proactive tools. And with this allowed us to be very responsive to COVID-19, so supporting the emergency departments, the intensive care units, quarantine units, long-term care, and personal care homes to maintain access and decrease exposure. So with this, I just want to acknowledge that we also have a provincial EMR, and so any sites that had access to that also had additional virtual visits. And Zoom for Healthcare was the solution that we deployed during the pandemic. So that was our newest piece of our hybrid model. So just looking quickly at the history of virtual care. So given the challenges in our province, we have a high rate of chronic illness, aging population, still many traditional values, financial impacts, and the last two are our biggest ones would be the physician shortages and the global pandemic itself and how that affected. So just to speak to the physician shortages, there are over 98,000, so we're Newfoundland Labradorians who do not have a family doctor right now. So that's a significant amount of our population that don't have access to a family doctor, which leads into our virtual ER services and the growing need for response there, especially on the primary care side. Just gonna skip right into that one. So our provincial virtual emergency services, so I have it broken out into 4 different areas. So due to the physician shortages, Category B emergency departments are having to close and go on full diversion. So in order to keep these departments open and functioning, they switched to a virtual emergency option where anybody of a higher CTASC would bypass this facility and go to the closest Category A. But anybody of a lower CTASC could still come into this facility and have access to a physician, nurses, and advanced airway paramedics to still have services, mostly on the primary healthcare side. So it did, allowed access within many of these communities. And to date, we're in our last few deployments, but we have 15 virtual ERs being established in this province. So that, as Cindy said, it's across the 3 regional health authorities, and then the northern region is using the second one, which will be the virtual urgent care. So that has been deployed for a number of years. It's using their coastal community care clinics to support keeping services accessible through virtual technologies, but we're upping, I guess, the the tools that we have there. So we are still upgrading those sites to make sure they have access to the advanced technologies. So that would be the examination camera and the stethoscope, as well as the telehealth units. So so the next one would be the NICU Eyes on Baby. So this is being deployed to all of our birthing sites provincially. Right now we have 3 sites live, our 4th one is about to go live. So this allows the neonatologist to see the baby and allow stabilizing the baby to transport to our regional center, or to potentially avoid an unnecessary transport so that they can be stabilized and kept within the facility that they were born. So this has been very successful to date, and there is a large push in our province to get all of our birthing sites up, because the neonatologists see an extreme value here. So this is one of our priority projects right now. So the last one is psychiatry on call. So similar to the physician shortages, psychiatry services are more based out of our tertiary sites. So there is on-call services available to support provincial needs, and it would be similar to prevent an unnecessary transfer, or provides on-call stabilization for a client in need. So just to have a quick look at the tools that we use. So similar to the 4 pieces that we just mentioned, the setups are all very similar. Some pieces are modified slightly based on need and individual use cases. But at the provider side, they can use a tablet. Sometimes they use smartphone, but we certainly prefer a tablet or a laptop. And then we use specific earbuds to make sure that the sound and quality is isolated for them. At the patient site, we either use an Amwell clinical cart or a built Ergotron cart with Cisco technologies. And then again, you can see our peripheral devices. We do usually pair an iPad with it to allow the stethoscope to connect to the iPad or the telehealth unit. But then in addition, there's more technology available just in case they need, there's extra emergency cases and they need to use the iPad to service more clients. So for next steps, we are moving towards a provincial CHR and provincial health record. So along with this, we're using our hybrid technology to continue to fully move towards the cloud and allow more integration opportunities. So the goal for us is to streamline our video technology into the solutions that clinical staff need, so within the health information system. So we're decreasing duplication of documentation, scheduling, and all of those pieces, so that video will be more accessible and more integrated into their clinical services. So we want to overall enhance the virtual care appointments. So we will be deploying more peripheral devices. So we are always exploring new technologies. Ultrasound is one area that has been brought up as options, and there's a couple other tools that we've been reviewing to see if we can add them to, especially to our emergency sites. So the next thing is adding advanced features. So this would be to help triage a client potentially within their home, add additional waiting room, virtual waiting room features, so that we can actually bypass them ever having to come into the facility for virtual. They will be triaged in their home and have the virtual appointment right within their home. So those are the goals that we're working towards. And further to that, we are looking to streamline our services with remote patient monitoring. So, right now they are 2 separate areas. So we are looking for opportunities that we can easily transition between our virtual care and remote patient monitoring to be more successful. Cindy, I'll hand it over to you for the conclusion.
Thank you, Ashley. So to support the adoption of virtual care and to advance in these steps, we're currently working on a few key elements. One is around the expansion of support services or support resources for technology. So this is to help with the adoption and use of virtual care, and to support clinics as well. We're also looking at digital literacy supports. So actually looking at the opportunity of developing credential courses for healthcare providers and training resources for all end users, including patients, around the use of virtual care. We're also having or utilizing health centers as a hub for virtual care appointments in areas where broad bandwidth is limited. And of course, one key point that we look at is choice, and want to ensure that choice is available and that we have options to ensure we meet the needs of our healthcare providers in the community.
excuse me, we've reached the end of our time.
Okay.
So I'll just ask everyone to connect with the speakers via the virtual event platform, and you can continue the conversation there. Thank you, Cindy and Ashley, for your interesting presentation on the virtual emergency rooms. Next, would everyone please head over to the virtual trade show to engage with the conference exhibitors. The booths are accessed at the top of the screen. See you there.